Hello, everyone, and welcome to this virtual meeting organized by B&B Dental and dedicated to the surgical technique, guided surgical technique. Today, we are going to evaluate two different surgical cases treated with the surgical technique, but following two different operative workflow. The first one is going to be the original workflow. I mean, two exam coming from a CT combine. The second workflow is going to use an alternative method that require an exams coming from the CT combine, and a second exams coming from the extraoral scannerization. Well, actually, I'm Angelo Banzi, and I'm a dentist. I've been working for 10 years for this company, actually for the development and research department, with a particular attention dedicated to the digital world. Here we have today, and I'm going to share this video with Alan. Alan is the technician of the B&B Dental, and he is going to give us the technical point of view for this technique. I'm going to leave the word to him to introduce himself, and you can go.
Okay, thank you, Angelo. I am Alan Betti, and I'm the dental technician for B&B Dental and the responsible for the guided surgery. Usually, I help the doctors to manage all the work, the technical workflow about guided surgery, from the first step to the last step, to the surgery.
Yeah.
And today, as already Angelo said, we're going to see two different cases. The first one is totally dentalism, upper and lower, if I remember
lower,
well.
yes.
Okay, upper
Immediate
and lower,
load case.
Immediate load, good.
Yeah.
And the second, the partial cases. So we can start with our lecture. Good.
I'd like to start our lecture with a refreshment, we can say, of the workflow, yes. Because the guided technique requires 9 operative steps to get the surgical guide. These 9 operative steps belong to 4 big family. The first one is the family of the capturing data. The second is the planning. The third one is the manufacturing, and finally the surgery time. And remember one important thing, you have to follow these 9 operative steps. This is really important.
Yeah.
Why? Because the guided technique can enter error during these 9 operative steps. And errors in guided technique are cumulative. What does it mean? It means that error over error, you are going to get a final big error that is going to make you fail. Is going to be a failure of your prosthetic rehabilitation. So it's really important to get how to treat every operative steps,
Yes,
and how to manage in the right way. So today you will have the dentist point of view and a more technical point of view coming from Alan.
Yeah. Yes, two words about the workflow because in BB Dental we created this kind of workflow to allow to the doctor to manage everything in a very easy way and arrive in the last step, the surgery,
Yeah.
in a very easy way and without trouble. So you have to follow all the steps.
Yeah.
Okay, good.
Let's see the first one. The first case, as Alan has mentioned before, it's a full arch rehabilitation, upper jaw and lower jaw, following the original method, this double CT combine scan. This method was, we can say, invented by Daniel Vanstenberg more than 15 years ago, and is actually a method that I use today. And it requires double exams getting from the CT combine. The first exams is the patient wearing a radiological template. The second exams, it's always a CT combine exams, but just the radiological template, the single radiological template. And just a few words about the radiological template, because this is a question that our doctor always and technician as well ask. Which material do we have to use to create this radiological template?
Well, in this case, is important. If you want, you can use a light curing base and bring into contact the raising with the antagonist teeth to achieve its stability. The best thing usually is use a prosthesis. A prosthesis, if you want, you can use the prosthesis if the patient has already a prosthesis in his mouth, the prosthesis of the patient, or if you want, you can create a new prosthesis and duplicate it in orthodontic resin or the resin for the prosthesis is the same thing, is not a problem, and you can duplicate it and put the radiopack marker on the radiological template. The best thing is use the prosthesis with the teeth.
Yes.
Why this thing? Because we have in the project, in the digital project, the position of the teeth, and we can put the implant
In the right position.
according to the prosthesis.
Yeah, guided by the teeth of the prosthesis.
Yes, good.
So, in the end, we can say that the radiological template can be done with a different material. I mean, I have the opportunity to get the two file immediately because in my clinic I've got the CT combine. So
good.
the first thing that I do when the patient come to my clinic is checking for the prosthesis in the mouth of the patient. Most of the time it has to be changed. So I require to my technician a new prosthesis that match occlusally, I mean, in the right way, and I'm going to use that prosthesis as radiological template. But if the prosthesis of the patient is well done, I can even use that prosthesis as a radiological template. I don't need any copy or a new prosthesis.
No. If you want, you can use the prosthesis, the real prosthesis of the patient.
But the problem is that most of the time, patient come because he's got a problem with that prosthesis.
Yes, good. So the prosthesis has to be really performant.
Yeah.
Okay. It's to feel good on the shape of the gingiva.
To fit in the right position in the mouth of the patient to be valid prosthesis to be used in this system, in this technique.
Yes, it's much important, especially that this prosthesis fit good with the gingiva. is
Yeah.
much important, because if the prosthesis moved in a patient mouth during the CBCT
Yes, but this
exam,
is yes.
it will be a big problem.
Yes, and you introduce another point that we are going to see better in the clinical case in a few moments. Anyway, let's go back to our workflow. So, what after I've acquired my data coming from the CT Combine, just from the CT Combine, what I'm going to have are two DICOM data. These two DICOM data have to be matched together, and is actually the technician is going to do this matching. And as you can see from this imaging, the matching, once it has done, it can be read by the surgical software. With the surgical software, I'm going to decide the perfect position of the implant, guided by the radiological template. That's why Alan mentioned that it's important to have teeth in the radiological, the shape of teeth in the radiological template, because I'm going to have a very important information, I would say gold information, because it's the only way to understand in which position I'm going to place the implant. And remember that the implant changed the position compared to the fact that I'm going to finish the case with a cemented prosthesis, or a screw prosthesis, or with straight abutment, angulated abutment, or multi-unit abutment, balls abutment. Every type of abutment require a different position of the implant, and having the perfect
proper position,
its proper position, and having a guide well done that match with the final position of the teeth of our rehabilitation. It's the first important things that this system requires. So let's move on, because after we have planned our implant position, we can send our case, our planning to the technician, and the technician, thanks to the CAD, is going to modeling in the virtual world the virtual shape of the surgical template, of what is going to be the real surgical template. And thanks to the CAM and a 3D printer, we are going to get the surgical template and the prosthesis. I mean, the prosthesis can be a temporary prosthesis, or the final prosthesis, the real one. So let's start with the first case, and as I mentioned before, this is a full arch rehabilitation, upper jaw and lower jaw, in the same day. As you can see from this imagine, this patient come to my clinic with a very bad, I can say, situation, difficult situation, because we just have two premolar in the upper jaw and a few teeth for the lower jaw. But this situation, and you can understand that this situation doesn't allow him to have a social life. So he's young, he's almost 50 years old, and I have to manage this situation in the best way and very easy way, I can say. And what I did was actually checking for the possibility to work in this case with the guided technique, because remember that not always I can use the guided technique. As you can see from the imagine before, I have a good shape of the alveolar bone. I extracted all the teeth, and after having healing of the soft tissues, I'm ready to start with the guided template, with the guided procedure. Why? This is really important. Second point is having a soft tissues static. The soft tissues is a tissues that have to be healed, have to be doesn't have any motion, and the ductility of these tissues can introduce problems. So the first important things is working with soft tissues that is stable and doesn't have any
yes, soft tissue, yes.
So I decided to work with the guided technique, and the first things that the dentists have to do is to take the impression. Let's have some information about the type of impression that we have to take, because everything starts from the impression, we can say. And as you can see from this imagine, I use double impression polyvinyl siloxane material. And as I told you before, the system required a static mucosa. So the first thing that I have to remind is that when I take the impression, because of the fact that it is a double impression, I do not have to push too much over the soft tissues. Most of the doctor ask me if is the polyether material a good material to get this impression, and actually it is good as the polyvinyl siloxane material, even if in literature there's some case where in literature it's said that the double impression, it seems to be more precise, a little bit more precise than the polyether material.
Yes.
And about this question, maybe Alan can help us to have to clear this point, because it's good. The question is, which material is the best material to get a good and a proper impression?
Yes, good. So, as Angelo already said, the polyvinyl siloxane materials are a good material. The double impression is a very good material. So because we have the possibility to take the first impression with the base material, and the second impression, the possibility to make the well shape of the
precision.
the precision.
Normally with
yes.
the light you get the precision.
Yes, the good shape, the best shape of the soft tissues.
And which the extension, I mean, of the, because I can take the impression with polyether material or polyvinyl siloxane with a double impression. It's actually the same. The precision is, we are talking about nothing, because the precision is really high. The worst material is certainly the alginate, I mean.
Yes, the alginate.
Can you take the impression? Can I take an impression with the alginate?
Okay. Better no.
It's better no. No. We have to say we have to say the line.
Yes, we have to understand one thing. So we have to transform your impression in a model, and on this model we have to design, we have to create the radiological template and the surgical template.
Yeah.
So much precise or more precise we have on the impression, and more precise will be the surgical
template and the final position of the implant.
and the final position and the surgery.
Starting using the best material for the impression is a good start. I mean,
Yes,
it's a
yes, a big-
start that is required to get a final solution that compare the real
Yes, it's a
implant
satisfied.
with, that satisfy,
Yes,
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 with,
satisfied
the virtual implant.
result. So the impression has to be the extension of the impression, as in these pictures. We have to arrive on the base of the fornix, and for the total dentalism, the upper total dentalism, and until the tuber.
Okay,
Okay,
until the tuber.
so
This is really important.
Okay, is very important,
So
because
extended, we can say extended flanges,
Flanges.
buccally, and what about the
until
palate?
the fornix, until the fornix, and the hard palate.
The hard
Okay,
palate.
until the hard palate, until the tuber, the tubers, the two tubers, and is much important, because we, in this case, we have to reach the best stability of the surgical template. In case of on the impressions, we don't take the point of stability.
Yeah.
Okay, like a tuber or like a fornix. In this case, will be a big problem for the day of the surgery. Okay,
Yeah.
because we have to extend the surgical template on the point that we allowed us to reach the
So
good
remember,
stability.
this is really important. The anatomical markers are the tuberosity, the maxillary tuberosity, and the labial and lateral frenule. Because when I'm going to place the radiological template, but not only the radiological template, also the surgical template, I'm going to check for this point that is going to give me the idea that the same position that the radiological template had during the exam is going to be the same position that the surgical template will have during the surgery. Just another point that I want to share with you is when I take the impression, it happens that sometimes I've got some bubbles, or maybe not empty area, or I don't know, some material shifted away, some laceration, and or maybe it's stretched the impression.
Yes,
I mean,
the stretch
all
impression.
these details, all these we can say that are errors, compromise my impression. My question is, if it's do I have to take a new impression, or sometimes I can avoid to take the impression and using that impression?
Yes, in this case, in case of a little bubbles,
Yeah.
is not a big problem. We can to remove from the impression, from the model, the plaster model,
Yeah.
the little bubbles is not a problem. But the much more important thing is the good shape. So the stretch impression, especially for
So stretched impression have to be taken again.
yes, you have to
Okay.
take again the impression.
Or
So
impression where the material it's shifted. I mean, like a double impression. A double impression mean impression
Yes,
over impression.
yes, impression over
because,
impression,
You
yes.
didn't get or place in the right position. Have to be retaken.
Retaking the impression is important, because as we already said, we're going to design the surgical template and the radiological template on your impression. So the impression has to be very precise.
So let's have a look also for the mandible. How is the way to get the best impression? I would say that if I have to check for the impression, the first important things is the extension. The buccal extension
Yes.
have to reach the fornix area,
Yeah.
the buccal fornix area, and for the lingual side, we can say we have to reach what the floor,
Yes,
which
the
part
floor,
it's
the lingual
important?
floor.
The lingual
Yes,
floor.
yes. It's
Okay.
much important as is the same thing of the upper impression.
Okay.
Okay, so
More
the
important, I mean, because
yeah,
it's smaller this area.
yes,
to be-
but the precise is the same thing.
Okay.
So we have to reach the maximum of the precise for the impressions. Because only in this case we have to achieve the maximum precision for
Okay,
the
okay.
day of the surgery.
Anatomical marker will be in this case the lateral frenulum and retromolar trigon. I have
Yes,
to
the
say,
trigon.
yes, I have to say something. Checking for the anatomical marker in the lower jaw is more difficult than compared to the upper jaw.
Okay.
I mean, the stability and checking the right position, maybe because I don't have the palate, but I have
Yes.
just a flange lingually. It's going to be tough to find the good position of the
the proper
radiological,
position.
the proper
Yes.
position of the radiological template and the surgical template. In my opinion, that's why the impression for the lower jaw have to be perfect.
Yes, yes.
This
It
is
has
really
to be
important.
perfect. Yes, it's
Have
much
to be,
important.
you cannot have any laceration and any stretch like we said before for the upper jaw. No MPT area, bubbles. Okay,
Yeah,
you can
yes.
handle bubbles as you said before and shifted material, but it's really important the extension of
Yes,
these
of the flange.
impressions.
Yes,
Of the
good.
flanges.
Yes, of the flanges. Yes, good.
You cannot invent virtual flanges.
No, it's not. It's not possible. It's not possible.
No,
but
it's a mistake.
yes,
It's going to be a
we have
mistake.
to say that the lower impression, usually the lower jaw is there isn't much gingiva like
No, there is
in
not
the upper.
keratinized gingiva
Yes.
as in the upper jaw, and also the resorption is going to be a big problem because for the lower jaw we have the tongue and
Yes.
the mouth floor that is moving. It's not like for
the palate,
the
yes.
palate area.
Yes.
Okay, and this is going to complicate all the case, all
Yeah.
the structure. So that's why most of the author in literature say that the big inaccuracy is in the mandible, because I've got a very high resorption of the alveolar bone, and working over the basal bone is going to be really tough. So as you can see from my case, I always work with a patient with a good alveolar bone. I mean, with an alveolar bone that is going to give me the possibility to fit the radiological template and the surgical template in a proper position.
Yes.
Proper position in this case means the same position. Let's move to the plaster model, the cast model, because from the impression what we get it's a plaster model, and as you can see from this imagine, my technician do not to have invent anything. I mean,
Absolutely.
he can see all the extension. You can see all the extension that is required to get a proper and stable prosthesis that I'm going to use as radiological template for the
Yes,
upper
good.
jaw you can see this area that
tuberosity area.
is the tuberosity, the maxillary tuberosity, the hard palate, the lateral phalanges, the anterior, the frontal phalanges. These are all marker, and as well as Alan mentioned before, the trigon, the
Yes,
trigon. The
retromolar,
trigon,
yes.
retromolar trigon is
Is much
important and
important.
marked as well as for the upper jaw
And the lower
we
jaw.
have for the lower jaw,
Yeah.
and the lateral marker is, well, you can see that it's going to be, I already know that it's going to be, and nothing is invented, everything is created from a good impression
A good
taken.
impression, yes, good. And just 2 words about the model. You have to develop the model in with low retraction materials.
Okay.
Is much important because, as Angelo already said, the guided surgery create a different level of errors.
Yeah.
So we have to decrease the level of the errors, and in this case, if you use a low retraction material, is like a hard gypsum,
Yeah.
or epoxy resin, if you want, is better than the normal material.
Okay, let's move on, because these prosthesis of the patient, that is actually a new prosthesis. My patient, I'm going to remind you, that came to my clinic
Yes.
without
Without.
any rehabilitation
Yeah.
in his mouth. So have to do everything from the beginning, from the start. Okay, so because of that, I decided to made a new prosthesis, a temporary prosthesis that I'm going to fix in the mouth of the patient as a temporary prosthesis after the surgery.
Yeah.
And this prosthesis is going to be the radiological template. And over the radiological template, the B&B Dental has developed an original technique, original method to allow the matching between the two exams coming from the
DICOM
CT
and
combi.
STL files.
Yes, from the two DICOM file, and this method wants to requires to use 5 radiopack marker, as you can see from the imagine. And what about these 5 radiopack marker? I mean, most of the patient or most of the doctor always ask which is the right position to place
Yes, the
this
proper
method,
position.
the proper position.
Yeah, yes,
These
good.
markers.
Yes, the proper position is the position that we can see on this slide, and one of behind central incisors, 2 on vestibular surface of canine, in position vestibular
Yeah.
surface of canine, and 2 on vestibular surface of the molar. Is much important is this position because the software align the STL file and the DICOM files by triangles. So in this case,
Well, actually, in this case, I'm not going to work with STL file, but a DICOM file.
yes,
Because
yes,
it's
but
a double, it's a double
yes, it is
origin.
a double acquisition, is
Yeah.
a double CBCT system. But even in this case, we have 2 different DICOMs file. We take the first the DICOM files of the patient with radiological, wearing the radiological template, and we load on our software. And the second image, the second DICOM's image, we transform the radiological template in
Yeah.
DICOM files.
Okay.
We transform it in STL files.
Okay.
So in this case, we have the possibility to match the 2 different files, DICOM file and STL files, by our radiopack markers.
Okay, yes. All right, so let's move on, because after I add my radiological template with the marker attached, what I do is checking for the proper position, and a proper position require a great and a big stability, and the big stability comes from the suction. When I've got a suction effect, as you can see from this imagine, it's really difficult
To remove.
to remove. Yes, the prosthesis that is going to be the radiological template after. Well, actually, it's difficult to remove from the mouth of the patient, and this is a very important
Yes,
point because everything start. It's true that everything starts from the impression, and the impression have to be good, but the position that we will have for the radiological template is going the position that we have to looking for the surgical template. So having the possibility to have this suction effect is going to give me the possibility to get the same position for the surgical template. So motionless, it's the key word of this part, and the only way to work in this case, it's having a good alveolar bone or a good keratinized gingiva. So
Yeah.
sometimes, as I told you before, it's really difficult to work with the guided technique in patient where I've got just basal bone and I cannot find a good position for the radiological template. In that case, I know that if I go on, I finish the case, probably I'm going to have some problem. But for this patient, as you can see, the stability of the radiological template is perfect,
It's
so
good,
it's going
yes.
to is good, it's motionless, and so I'm sure that the position of this radiological template is going to be kept also for the surgical template.
Yes, or even in this case, the teeth give you the possibility
Yeah,
to
sure.
reach the perfect suction of the prosthesis and without trouble, without motion.
Yeah, absolutely. So let's move on. So we can say that at the beginning we will start working with two DICOM exam. One is coming from the patient wearing the radiological template, and you can see in this view that the radiological template, because it's resin, it's you cannot see in these exams, but what you can see is the bone of the patient and the radiopack marker.
Yes, the much important thing.
The much important things in this case. For the second radiological template, you can see the radiological template. For the second exams, it's required just the radiological template. Now, in this case, you can see the radiological template. Why? Because the second exams normally is taken with a low irradiation. If you have to set the CT combine or ask for a setting, this setting is going to be the same that we use for children. With a low irradiation, we are going, and Alan is going to have the imaging of the radiological template and radiopack marker. And actually, once that I've got this file, I'm going to send to Alan these two exams, and Alan is going to matching these exams as well, as you can see from the imaging. Do you want to give us
and
some?
we have already said we transform the DICOM file of radiological template in STL files.
Both of them or just one?
Both of them. Yes.
Both of them are
the
yes,
upper radiological template and lower radiological template, and we can take from.
The question is, for the technician, maybe this is a question very interesting. Do you have to transform both exams? I mean, the first one of the patient wearing the radiological template, or just the radiological template?
No, just the radiological template.
So
both, I mean, both upper and lower.
of the radiological
of
template. So just the
radiological template.
radiological
Yes, just
exams
radiological.
is going to be transformed in STL file to be matched with the DICOM file of the patient wherein the radiological template.
Yes, and then we transform the radiological template, the DICOM files of radiological template in STL files in order to align these two different files
Yeah.
by our RadiPack markers, and we can obtain from the radiological template the mucosal part.
Yeah, this is
Okay.
really important
Yes,
because
because we have to. We are
the CT
there are-
combin doesn't allow to have any soft tissues.
No,
Okay,
yes,
in the
yes, it's
imaging.
not
So
possible.
the question is, where do I know where is and how is the shape of the soft tissues? Well, Alan answered us because he revealed us that the soft tissues come from the inner face of
Yes.
the radiological template. That's why when a patient come to your clinic and you are going to use his prosthesis as a radiological template, it's important to rebase always
Yes,
the
it
radiological
is
template
much important.
Yes, because we need the perfect impression, the perfect copy in that moment of the soft tissues.
Important thing for rebase the prosthesis, don't use any type of silicone.
Okay, why?
Okay, because usually the silicone create a scattering effect because contain on the liquid
Part,
or
yes.
the liquid part the some pieces of metal.
Yeah.
A micro particle of metal, yes, but create a scattering effect. So use just the resin for the prosthesis.
Yes, and check also in the liquid part, in the resin liquid part that you are going to use to rebase your prosthesis. Well, check if there is metal, because the metal in the mouth of the patient can be cause of scattering effect. It's very little in this case, but it can create a deformation that is more a swelling of the imagine, and the final fitting position of the surgical template can be a problem
Yes,
if it
yes.
happens. So it's very important. Check for the material you are going to use to rebase
Yes.
the
Much important.
the radiological template.
The prosthesis.
The prosthesis when it's going to be a radiological template.
Yes.
Because if you do a new one, you won't have this problem.
Yes. Good.
So once that Alan has received our files, he's going to matching this file, as you can see from this imagine. As he mentioned before, he transform the DICOM imaging of the radiological template in a STL file.
Yes.
And thanks to the RadioPack marker, he is going to match together the two exams, as you can see from this imagine. But maybe we can see. Let's have a. Do you want to say any words about this part?
Yes. Yes. Okay. So first, this is our software. Okay?
Oh yes,
This is our software by B&B Dental. Is much important because in B&B Dental we created a software.
Yes, a software. The
Yes.
items that you are going to
our
see,
own software.
It's original, coming
Yeah.
from the B&B Dental.
Yes.
And the software, it's a software developed by our company. And is it free? Do we have to pay for this software?
No, it's not.
What can you
The
achieve
software
with this
the software is free for our customers, our clients. We can give them our software. You can download this software from our website, B&B Dental's website, and in this case we can see how we can
match the
match
two imagine.
the two imaging.
Yeah,
Okay.
and with the same software that you can download from the B&B Dental,
Website.
yes.
Yeah.
Thanks. With the same software, you can handle the matching, the
Yes, you
planning,
can have
and
everything. Everything.
the preparation of the radiological
No,
template.
the surgical template.
The surgical template,
Yes,
sorry,
good.
yes.
The surgical template, and if you want the model, because if you want to
Also the
create
model.
a immediate loader,
So it's a software
okay.
like that allowed us to have a CAD/CAM. It's a CAD/CAM software. sort
Yes,
of.
it's a CAD software.
CAD software.
The CAM
CAD.
is the
Yeah,
milling
it's the
machine.
part.
Yeah,
Yeah.
and you can manage to everything: the importation of DICOM files, matching, importation
Everything.
of STL file,
Once
everything you want.
that the matching is done, Alan is going to send me the Imagine, the software, and with this part, I will be able to do what? I will be able to planning the implant position.
Yeah.
Now, I don't know why it hasn't started. Anyway, let's
start.
helps. Yes.
But there isn't the
video?
music.
No, I say I removed the music, and actually, this is a very important part as well as all the operative 9 operative steps, but this comes from the knowledge of the dentist, we
Yeah.
can say. The knowledge that the dentist had from his clinical experience. I mean, as I mentioned before, implants are, you have to place implants in a different way. Compare to the fact that I'm going to fix the prosthesis with a cemented prosthesis, or a screw prosthesis, or a ball abutment, straight abutment, angulate abutment, multi-unit abutment. Every type of fixation, we can say, with the abutment require a different position of the implant. And as you can see from this, imagine the fact that the radiological template has got teeth help me to understand which is the right position of the implant. I'm starting always checking for the soft tissues, the measurement of the soft tissues, to have an idea of which length I'm going to have about the abutment.
You can do as in upper jaw, the panoramic view. You can do you can do everything with our soft. Yes.
Yeah. But I mean, with I was saying that with I'm starting with the measurement of soft tissues, bone tissues, because I know everything about the type of abutment and implant that I'm going to use. I mean, with this technique, I'm going to manage everything. I'm going to decide the type of implant, the position of the implant, the inclination, the abutment, the length of the neck of the abutment, which type of abutment. I can check for the parallelism. I mean, do you change?
Yes, there is a button. Yes, there is a button on there is a tools on our software that you can place all the implants you want, and then you can put on the same axis.
Okay. Yeah. This is really
if you
important.
If you want, during your planning, you can parallelize all the abutment one to one during
and this
your
is
planning.
Really important, because this is what we want to work when we work with what we want to have when we work with the guided technique. I mean, it's not only simplify our life, our surgical life. It means simplify all the system,
steps,
all the system, and also the technician work. I mean, the technician sometimes have to be really good to cover the implant mistaken position
Yes.
of the dentist.
Yes.
With the guided technique, this is going to be avoided, and our technician is going to be very happy to work with a good implant position.
Yes, and
Ear
to
position, I mean.
facilitate the prosthesis construction.
Yeah, yeah.
Yes, and to put the implant in aesthetic position.
In an aesthetic and functional
Yes.
position. This
Yes,
is really
is
important.
much important. Yes.
And again, check for, as you can see from this imagine, I'm also checking for the sleeves.
Yes.
As you can see here, I've got, I have, and this is a part that I forgot sometimes, because, and it is an important item, because sleeves require a distance in the guided template that is a standard distance.
Yes,
It's
4
always,
millimeters.
yes, 4 millimeters.
Yes.
It doesn't change, okay? And the fact is sometimes when I place the implant, I want the implant 1 or 2 millimeter under the level of the bone.
Yes.
And
According the
according
think
the-
about
No,
of the doctors.
well, actually, according to the knowledge and the experience of the dentist, maybe sometimes he wants
Yes,
to
good.
place a bone level. I prefer 1 millimeter or 2 millimeter under the level of the bone.
Yes.
And in that case, it happens that the sleeves, the bottom part of the sleeves, can enter into the soft tissues,
So it
or
goes in
maybe yes, can touch the papilla, or maybe because the inclination of the implants is too buccally or too lingually or too mesiodistal inclinated, it can touch the soft tissues. Well, what do I have to do? Because most 5 years ago, when I started working, the only option that I had was opening
the
a
flap.
flap,
Yeah.
and most of the time I try to avoid this opening, to open any flap, because I want to give a post-operative situation
Yeah.
to my patient, a better post-operative healing, and it's good when you don't open any flap.
Yes,
So,
so-
do I have to open a flap? The question is,
No, so
do I have to open?
if you want to open the flap, you can open the flap. Is not a problem. We can leave the sleeve in a standard position, and
Yeah,
if
actually,
you want,
yes.
you can open the flap. Is not a problem. But if you don't want to open the flap, we have figured out this problem. We have solved this problem because the guided surgery was born to agevole, to facilitate the clinical part, the surgery.
The surgery and also
and
the
the
technical
healing,
part,
yes,
yeah.
and the healing of the patient, the soft tissues on the patient. So in this case, we have figured out this problem because we have
Like
to.
we can see here
we have to
from
find
this imagine that the
yes,
sleeves
for that sleeve.
enter
It goes
into
in collision,
yes, it's in collision with
on the
the
much
soft
part
tissues.
of his length is in collision with the anatomical part, and in this case is a big problem because if all the sleeves go in collision with the anatomical part, they could destabilize the surgical
Yeah,
template,
yeah.
and it will be a big problem
Yeah,
for,
not only
for the
you have
surgery.
to open a flap, but it can not allow the right positioning of the surgical
Good,
template.
good.
Yeah.
So in this case, we have to find the solution, and we can move up the sleeve in position +2, so we can move up the sleeve for 2 millimeter or
4
4
millimeter.
millimeter.
This is in the
case,
virtual world, okay?
Yes,
just in
just
the
in the
virtual
virtual
world. I mean,
Yes.
during
virtual
this
planning.
process, the technician,
Yes.
or I can do it by myself.
Yes, yes, if you want,
I
it's not a
move
problem.
2 or 4 millimeter upper the standard position.
The standard
of the
position.
sleeves.
Yes, in this case, you can remove the sleeve from the collision with the anatomical part, with the soft tissues, and you don't need to open a flap, and
Yeah.
the
But
surgical
yes.
template will be stable on the
And
soft tissues.
remember that this for every trick that I play, remember I have to pay something,
Yes.
because sometimes when I move 2 or 4 millimeters, an implant, in the end have to work with an implant shorter of 2 or 4 millimeter. But
Yes.
to avoid to have the implant 2 millimeter on the level of the bone, or avoid the opening of a flap, sometimes he works. This trick works.
Yes, yes. So if you have a sleeve +2, you can work with implant maximum 12 millimeters.
12 millimeter, yes.
Okay, so because 12 millimeters of implant and sleeve in position +2 is 14 millimeter, and 40 millimeter is the longest drill that we have in our surgical kit.
This is a trick that we invented, we can say invented with our company when we notice this problem, and it's very easy to be played. But remember that for this trick there is a kit, a part of the kit dedicated with tools with +2 or +4
yes.
to allow you to insert implant, or insert implant in the right position.
Yes,
anyway,
in the proper position.
Let's
Yes.
go. Once that I've placed the implant and I've checked for the abutment, the parallelism. Also,
Yes.
another important things is do we need always to work with a perfect parallelism
No,
of the abutment?
no. If you use a multi-unit abutment or flat abutment, you don't need to paralyze perfectly all the implants.
Okay. Yeah. The range of tolerance is
15 degrees
15
between
degrees, okay.
one implant and other implant is not problem, because the multi-unit abutment have a
Okay.
little cone on it,
Okay.
and you can
handle this situation.
handle this situation. Yes,
but
it's not a problem.
the parallelism is required
Is
when?
absolutely required when you use a normal abutment, a
Okay,
standard
a
abutment.
standard
So you
abutment.
have to paralyze perfectly all the implants with the abutment, with
Yeah.
angulated abutment. 15 and 25 degrees. You can use this abutment to paralyze in a proper way all the implants. Yes.
Okay. Let's move with the CAD software. This is the technical part. Is the technician that is going to design virtually the surgical template, the virtual surgical template, and this is just a video that Alan has shown me how he works. Maybe do you want to give some tips, or just do you want to give some tips for this preparation, or it's okay?
No, it's okay, because
Well, it's
is
very
is very
technical, this
intuitive.
one. Yes.
But is very intuitive. So the doctor, if they want, can share with us by cloud, because into our software is a cloud. Is preparation, is clinical preparation, is clinical planning, and we can do everything about on a surgical template.
Okay.
Or if you want, you can manage to everything in an independent. So if you want, you can create you can
but
create
actually,
a surgical template.
I'm not
It's
able
very
to
easy.
do it, and so I prefer to send these
Yes,
planning
yes.
case and asking you for the preparation of the surgical template, the
yes.
virtual surgical template. Once that the virtual surgical template is done, and
We put them in a 3D printer.
yes,
Okay.
we can move to the next steps, that is print to create, to change from the virtual world, the real world, to take it from the real world, from the virtual world to the real world, the imagine. And this is thanks to the 3D printer. Some few word about the 3D printer. Do you have some
advices.
yes, some advices maybe which is the best, not the best printed because most of them are
Yes,
good,
yes, very
but to get a very and precise surgical template.
Okay.
Which characteristics has to have a 3D printer?
Not much advice on it because 3D printer today, the 3D printer on the market today has all precise, and there aren't not much problem about
Yeah, but I
on a
mean,
3D
yes,
printer.
but I
Yes.
mean, I want to be sure. I'm a dentist, and I want to be sure that the technician is going to use a good 3D printer, a precise 3D
Yes.
printer. 3D printers works
The-
creating layer
the
over
slice,
layer.
yes.
Yes, slice of layer over layer, the 3D object. Okay.
Yes.
In this case, the surgical template. Which is the best thickness of
Or
layers,
the minimum thickness, yes, that you can use to print
get a
the
very precise surgical template,
Yes.
which is the thickness of these layers.
okay. The proper thickness is 20 micrometers or 25 micrometers is good, is not a big problem. Don't exceed the 50 micrometers because
It's
it
going
could
to
be
be okay.
a little bit problem because it's not much precise.
Okay. So lower than 20 micrometers.
Yes.
It's a good range. It's the perfect range
Yes.
to work with to get an object, in this case, a surgical template, really precise.
Yes.
Precise. When I say precise, I say that it's identical or much more identical to the virtual
Yes.
surgical template that we have planned with the case, with the software.
Yes, the CAD.
Okay, so let's move on with the surgery. Very easy. This is the case, and fast. I'm going to with the punch tools drill the soft tissues. As you can see from this imaging, it's very clean, minimal invasive procedure, and I'm going to have a better healing of the soft tissues.
Yes.
We are going to use I'm going to fix the surgical template over the alveolar bone, and we started working with the lateral pin, but we noticed that these lateral pin were not enough, especially
Yes.
for the fact that in the posterior, most of the time lateral pin are placed in the anterior part,
Yeah.
and the posterior area doesn't fit properly over the keratinized gingiva. So we introduce this second pin that we will call crestal screw. And as you can see from this image, what happened in the posterior part is that the surgical template laid out. It doesn't touch really. It
doesn't
detach.
fit. It doesn't fit good. Yes.
Properly over the keratinized gingiva. So in that area, I'm going to fix the posterior part with the crestal screw.
Yeah.
I always match lateral pin and crestal screw when I have to place implants in the molar and the premolar area. I want to be sure that the fitting is going to be perfect.
Yes,
Okay,
good.
they are very easy to be used, and they can be placed in the sleeves that in a second time I'm going to where I'm going to place the implant. So in the first time I'm going to place the implant in the anterior part, and with the mounter, that is the last we can say system to place to fix the prosthesis, not only to brings the implant. After I've placed the anterior implants, I'm going to remove the crestal screw, the posterior crestal screw, and I'm going to place implant in
Yeah.
that area.
Okay.
Okay.
Okay. See, just two word about lateral pin and crestal pin.
Okay. Yes. Maybe I'm going back because
Okay.
I was okay.
Okay. So
Yes.
the lateral pin has a proper sleeve, titanium
Yes.
sleeve. Okay. The crestal pin goes in sleeve for implant.
Yeah. Yeah.
Okay. So and we have two different crestal pins. One of the little sleeve, 4.2 millimeters, and
Yeah.
one of the
It
biggest
depends
sleeve.
which type
Yes,
of
according
implants you want to use.
to want to use, and according to the thickness of the soft tissues. Okay, you can
Okay.
use the crystal pin according to the
Because
implants
because
and
the crystal screw has different lengths.
yes,
Okay.
two different lengths.
Two
Okay,
different
and
lengths.
two different diameters.
Okay, drill sequence is always the same, the one that you will have for the traditional technique. Step by step, I reach the same diameter of the implant. In this case, first I have to prepare the lens with the smaller, the yellow drill, we can say. And then once I reach the length of the implant, I make it wider, okay?
Yes.
And I reach the same diameter of the implant that I've chosen. I can also use the compactor, it's up to you. Usually I use it in the upper jaw to increase the stability, the primary stability of the implant.
Yes, it's much important, the
Yes,
compactor.
because it's osteocondensation, we can say it create. After the surgery, this is the imaging that is the same imaging I had before. Is not the same, but nothing
Yes,
has changed.
after the punch drill.
Yes, after everything, nothing is changed from the first imaging. In this case, I'm going to place the multi-unit abutment, and I've checked the parallelism of this multi-unit abutment, and I'm going to fix immediately after the implant insertion with the temporary abutment the prosthesis of the patient that I've used before as radiological template.
Yeah.
Now this is the imaging. You can see the perfect fitting of the implants and the multi-unit abutment with the provisional
temporary abutment,
the
yes.
temporary abutment. This is the case of the patient, and let's see, because in the same day I decided to perform also the lower implant positioning, and the case is always the same. So guided tissues punch, I remove the soft tissues, I place again the surgical template, and with the drill, step by steps, I prepare the implant site. This is the crestal screw. Remember, the lateral pin are not enough, so I decided to place also the crestal screw in the posterior area to avoid this movement. Okay, let's move on, because these are the two imaging, lateral pin and crestal screw in the posterior area, to have the best fitting of the surgical template. And again, the preparation of the implant sites and the insertion of the implant sites using the mounter. As I told you before, as I mentioned before, the mounter can have a standard lens, but in this case it's green because it's a mounter +2. It means that in this case I've played the trick that we have talked before. We are taught before, and it's the fact that maybe the sleeves should have touched the soft tissue. So Alan changed 2 millimeter more the position of the virtual sleeves, and in the reality I have to use a drill 2 millimeter bigger and a mounter with +2, a mounter 2 millimeter longer to reach the same position of the virtual implant for the real one, the real implant. Now lateral pin, crestal screw and mounter are my option to fix the prosthesis of the surgical template. Drilling, implant insertion, match always the hexagon head of the mounter with the shape of the sleeves, because this matching is going to bring the parallelism that I have chosen before in the virtual world, in the virtual planning of the abutment.
Yes, mostly if you use the angulated abutment.
If you use the angulated abutment.
Because the matching between hexagon of mounter and the hexagon of the sleeve allowed you to find the perfect position of the hexagon of the implant and the perfect position of the abutments, angulated abutment.
Let's move on and let's see the final case. How I finish this case, because as I told you before, in the end I decided to place to fix both of the prostheses in the mouth of the patient, and this is the results. It's perfect. The matching is the occlusal matching. The occlusal matching allowed the patient to have a function again, not only the aesthetic, as you can see from this image. Now, this is the final X-ray of the patient. I took also a CT combine because I wanted to be sure that the implant were placed in the right position, the position that I've planned before. Now, let's see the second alternative workflow, because we said that this workflow, I mean the workflow that we have seen until now, is the workflow that works in the best way for a full arch rehabilitation. We can say, in my experience, is the original. I always work with the original one. In case of full arch rehabilitation, remember always to check for the resin that I'm going to use to rebase the prosthesis, the radiological template, because it can contain metal. Why metal? And the metal is the fact that in the year it has been checked for an alternative method. The metal in the mouth of the patient can create a scattering effect, but if I understood well, also teeth can create a little bit of a scattering effect. That's why in the partial patient, maybe the best way to work is following this alternative method that is going to require you a CT combine exams of the patient wearing the radiological template and a scannerization of the plaster model and radiological template.
Yes.
Is it true?
Yes, perfect. So, in this case, for partial dentalism, we have two different ways to perform the CBCT. The first one is just the patient. Just
without the radiological
without
template?
the radiological template.
Okay.
So, in case, but just in case, the patient has a lot of teeth in his mouth. So, when I say a lot of teeth,
you mean
not 6 anteriors or 6 posterior teeth. So, but two canines and two molars are enough to perform the matching. So a lot of teeth in his mouth, a lot of teeth, 4, 5 teeth in his mouth, and
Just
in
for 5 minutes in his mouth. I mean,
yes,
you
is
need
enough. Yes,
enough.
yes, they are
Okay,
enough
because you
to
are going to use.
perform
Okay,
the
okay.
alignment by teeth, and the mouth of the teeth is have to as to free from metal.
Okay,
Okay,
absolutely free
free
from
from
metal.
metal, crowns, bridge, big reconstruction. If you have just 4 teeth in the patient of the mouth and you have 2 teeth where there is a big reconstruction,
Okay.
you have to use the radiological template. So, in case of the patient, the patient mouth is free from metal and there are some teeth in his mouth, 4 teeth, and not just
But
for
wait,
anterior
wait.
and for molars.
Okay, this is a technical. Okay,
You
this is
can
a
use
technical tips.
yes.
But honestly, if I have just 4 teeth,
You prefer to use the radiological template?
I always
Yes,
prefer to use the
yes,
radiological
it's
template.
good.
Just in case I'm going to work in a single tooth rehabilitation or a very short
Yes,
fixed
yes, good.
rehabilitation, I'm going to avoid to work with the radiological template. And maybe in that case, I'm going to use also the intraoral scanner. But
Yes, good.
normally, to reach a very high precision, what I want is also is working with the radiological
Yes,
template.
if you
in
want,
my
yes.
opinion,
Yes,
but
yes.
he is the technician and he's here to lead us in a different view that anyway works.
Yes, good, because a lot of doctors ask me if it's possible to align DICOM files and just the model without radiological template. So there is the possibility, but there are some advice to follow to reach the
Okay.
good preparation.
A good
So
preparation.
you have to use the radiological template if the patient has a lot of metal in his mouth, crown, bridge, and big
Yeah.
reconstruction, and in case of total dentalism. Okay. So in case the patient has a lot of teeth and the mouth is free from metal, you don't need of a radiological template. But if you want, you can use also in this case the radiological template is not a problem.
Okay. So this method is different from the original one because of the fact that the acquisition of the data of the files come one from the CT Combine, the second one from an extraoral scannerization. Okay.
Yes.
What do I'm going to get from this extraoral scannerization and from the CT Combine? From the CT Combine, I'm going to get the bone of the patient.
Yes.
From the extraoral scannerization, I'm going to get the soft tissues, the radiological template, if I've used,
Yes.
and the teeth of the imagine. Now,
yes, in this case, you have absolutely need to take an impression. If
sure.
in the case before, if you
Yeah.
use the processes of the patient,
Yeah.
you don't need to
Okay,
take
the
an
impression,
impression.
yes, the impression is because of the radiological template.
Yes,
If you don't use the radiological template, you just need
If you want, so you have, we need even of the impression
okay,
because
yes,
we
sure,
have
sure,
to
sure.
take about
Sure.
But you can use, if you want, the intraoral scanner.
Yeah, sure.
If you don't need of the radiological template, you can use the intraoral scanner.
So you always need an impression to get the plaster
Yes.
model. You are going to scannerize the plaster model
Yes.
without the radiological template when you've got a lot
Yes.
of teeth and matching this imagine with the CT Combine imagine of the patient.
Yes, good.
In this case,
Yes,
not
good.
wearing anything.
Yes.
Okay?
Yes,
This is the point. But most of the time, I always prefer to use the radiological template,
Yes.
honestly.
Yeah.
Anyway, once that I've got this imagine, I'm going to match, the technician is going to match this imagine, and from here to the end is
Always the same.
identical.
Yes,
Okay, the
always
method,
the same.
it doesn't change. I mean, with surgical software, I'm going to plan in the implant position and I'm going to choose the abutment.
Yes.
With the modeling software, I'm going to, the technician is going to design the surgical template
And the model, if you
and
want.
the model. With a 3D printer is going to create the real surgical template, and with the CAD production is going to create the prosthesis.
Yes,
Okay, now the only thing that is different again, it's the method we acquired the files.
the CBCT,
okay,
yes.
once
And
it comes from the CT Combine, the second one
From
it
the
comes
laboratory
from
scanner.
the laboratory scanner. Yes, let's see this patient. It's actually this is a single mouth case. Okay. Oof. Okay, he's a very young patient. Anyway, he need restoration of the molar, the first molar in the third quadrant. And what I'm going to do in this case, well, this is a very old case, and in this case, I took an impression, okay, a double impression. That is the most precise impression for
yes,
the
good.
literature.
Especially if you have the teeth in the
Especially if
patient's
you have
mouth,
teeth in the mouth.
because for the total dentalism you can use a silicone, polyether silicone.
Yeah.
But in this case, if you have the teeth and we have to take a good shape, the perfect shape of the teeth, you have to need the double impression,
The double
base
impression.
and light.
Yeah. Also, I'm going to get the plaster model, and over the plaster model, as we mentioned before, we create, in this case,
The
radiological template. But this is a very old case. As Alan has mentioned before, the second file, and it does, in this case, it's just one teeth, so it's not necessary the
Absolutely,
radiological template.
is a very young patient.
Yeah, but it doesn't mean, I mean, it's got teeth.
Yes,
It's got
yes,
teeth.
but he's got teeth, but she doesn't have metal in his mouth.
Yes,
because
also.
he's very young, and he doesn't have a metal in his mouth, and there isn't just one teeth. But in this case, if I remember well, we don't use the radiological template.
You didn't use the radiological
So
templates because
we
it
have
wasn't
we
necessary.
create the radiological template. We perform the CBCT with radiological template,
But
we don't matching the.
we didn't match the radiological template. It's just
Yes.
what he did was matching just teeth
That,
with
but
teeth.
just by teeth,
Okay.
yes.
As you can see from this image, yes, because we noticed from the beginning that in this case where I've got a full arch, an arch full of teeth,
Yes.
I can use teeth to get the matching. Okay, in case I don't have so much teeth, it's important to have the radiological template. That in this case is what is it? This radiological template actually, it's
yes, is
printed.
It's printable base.
Okay.
Yes, in plastic. And
Printed individual guide. It's very simple, very easy to be checked in the mouth of the patient.
You have to use rigid plastic.
Yeah.
Okay. 1.5 millimeters is enough to perform this radiological template, and put the marker as we already see for the totally dentalism.
And as you can see from this imagine, I didn't ask for a workshop, a real workshop, because the workshop is going to be done virtually.
Yes, into the software.
Yes, all the system can be treated in the virtual way. We don't need to use working with the digital technique, any material.
Yeah.
So one file come from the CT Combine, the second file from the extraoral scannerization, and what I got from the extraoral scannerization are these two images.
Yeah.
The first image is the radiological template over the plaster model. The second one is the plaster model with teeth, just the plaster model.
Just the
so
plaster model,
soft tissues and teeth. And Alan, as mentioned before, in this case, because we got all teeth, he used just the plaster model.
Yeah.
So in this case, the matching is going to be done. It should be this one, but it's not, because as is mentioned before, he decided to match the case without using the radiological template, but just teeth, because I've got a lot of teeth. And this is the matching, as he mentioned before, from the extraoral scannerization. Again, we get the soft tissues and the teeth, and we got everything in the imaging, and this is actually the matching. Let's see. This is the plaster model, and he is going to use just the teeth to matching these two images.
Yes.
It's true that we have also the surgical, the radiological template, and it's
Yes.
true that the radiological template will give us another information of
Yeah.
matching. Okay. Sending now that the matching is done, the case is sent to the dentist, and the dentist is going to to decide the implant positioning. As I told you before, as I mentioned before, I didn't ask for a real workup at the beginning, but I asked for a virtual workup. So what Alan is going to do is to create an image.
Yeah, so the design of the
we are okay. But this
is the surgical template.
Okay. Yes, because I I jump the part of wait.
Yes.
Okay, this one. This
Okay.
is the part of the surgical guy production. But what is the part? Okay, this is the works up. Okay, the virtual works up. Okay. And after
the positioning of the implant.
Yes, I did the implant positioning. Okay, thanks to the workup, I did the implant positioning. Now the case is sent to your technician, and the technician is going to create what
the design of the surgical template.
Yes, the design of the surgical template,
okay.
As we have seen before.
Okay. The design of the surgical template, if you want, you can create some holes on
like here.
The surgical template check the position, the proper position of the surgical template, or if you want for some anesthesia.
Yeah.
Okay. Behind the sleeve, the place where you want to put the implant.
And as you can see from this image, the printed template has got the hexagonal shape, and this hexagon, it depends by the positioning of the inside hexagon of the implant that I have chosen during the implant planning.
Yes, good.
Okay, this is really important because I've chosen the right inclination of the abutment especially when it is is an angulated abutment.
Yes.
Okay. Now we are going to attach the sleeves. In this case, is a PIC sleeves. Yes. Can you tell something about the PIC sleeves?
Yes. PIC sleeves is a very great material because
just a few words. I just want to say a few words because when we start working, I don't know if you remember, we use the metal sleeves.
The metal sleeves. Yes.
And we choose to not. We got the metal sleeves, but I prefer to work with the PIC sleeves.
Yes, the PIC sleeve.
Yeah,
Yes, the
and
PIC is a very great material.
yeah, but because we had the problem at the beginning working with the metal sleeves because of the friction effect that can
Yes.
create a problem of the rotation of the drill.
Yeah.
The friction is a physical effect that we have when two metals works, one metal rotated into
And the
another
other static. Yeah.
metal, and it can create problems to the rotation. And it can overheat. So we didn't we weren't really happy or about these leaves, these metal
good.
sleeves.
Yes,
Okay,
yes,
so we search for a different material that allow to work in a proper way, with in a easier way and in a much more precise
Yes,
way,
because to avoid the friction metal, you have to use you have to take a big
Tolerance.
gap, a big tolerance between the sleeve and
the metal
the
sleeves
drills.
and the metal sleeve.
The metal drill. Yes,
Drill.
okay. So in this case, the drills, the sleeve doesn't guide the drills in a very really proper position. So with the
PIC.
PIC sleeve, instead you have to take very little tolerance, the very little gap between sleeve and the metal of the drill, because the PIC doesn't overheating
Doesn't overheating,
like the metal.
Also it so in the
Is
end
much is
it's
more precise,
because the sleeves is big, is
is
smaller,
plastic.
smaller.
Oh, yes, and is a plastic material,
Yeah.
so doesn't overheating. So you have to take a little gap, and the sleeve can guide the drill into the bone
In a proper way.
in a
Yeah.
proper precise, in a very precise way.
In a more precise way.
Yeah.
Let's see the case. We are at the end of this presentation, actually, and let's see this video. It's just 2 minutes, 3 minutes of video, and what we want to say to you, it's that this method, it's really it really works, and you just have to know the operative steps and follow these operative steps. You cannot jump from steps to another steps. Actually, the doctor doesn't do a lot. It just have to take an impression in a proper way, but we always take an impression in a proper way.
Yes, good.
Also for other technique. And it just have to send the impression to the technician. The technician is going to create the radiological template, and we have to check for the position. Second point, we have to check for the right position of the radiological template. Once that the radiological template is done,
you said a very important thing, because after the construction of the radiological template, before performing the CBCT exam, you have to call the patient into your dental studio. Okay,
Yeah.
check the proper position of the radiological template, both for total dentalism and for
always.
partial dentalism. You have to teach to the patient how to place in the proper position the radiological template, especially if you send the patient into a radiological center, and you don't have the
if you don't have the CT combine in your
combine.
clinic,
Yes.
you have to send your patient. And the point is, one, you go with the patient in the radiological template and you help to place the radiological template, or you can teach how to place. It was funny.
It's very
Yes,
important.
it was funny because one time one patient went with his wife to the to the clinical radiological
Center,
yes. And actually the man used the prosthesis, the radiological prosthesis of the wife and the wife of his husband.
Yes,
And
good.
it was a problem.
Yes,
There was a mistake.
really.
Okay. Yes, this this is a mistake. So if you have the CT combine in your clinic, it's going to be much more easier for both
Yes,
the
good.
patient and the
Yes,
dentist.
but if you teach how to
Yeah, it's
place
good. Yeah.
the radiological template to the patient is better because the patient can give
It's
you
good
or
as well.
can
Yeah.
give you the radiological center a feedback on the proper position of the
But
radiological
anyway,
template.
so we take an impression, we check for the surgical template, and after that we just have to planning the implant case. That's it. Three things, 3 point, and everything, and the other operative steps are made by the technician, and um, and then we perform our surgery as we can see from the imaging.
So
This technique really works, and works. It helps. It helps a lot, not only for an aesthetic results, but also for a functional results. The implant is going to be placed in the perfect position, the best position that you can even that you cannot even reach with the traditional technique, because when the virtual when you work with a virtual technique, you can reach a very precise
Yes.
and accurate
Yes.
implant
yes, because you
positioning.
already know the doctor or already know the position of the implant, the inclination, the really deep
Yeah.
of the implant, because we planned the case before the surgery. All is already planned. So okay, is much important.
Anyway, this is just two cases. One total full arch rehabilitation. The second one is a partial arch rehabilitation. Well, it's a tooth restoration. And there should be much more to be said about this technique, but this is just a webinar, just a meeting, a virtual meeting. I hope you understood this operative point, and how to perform in the best way the surgery. If you want to join us to have much more information about this technique from a technical point of view,
Yeah.
and not only from a clinical point of view, you are welcome in the courses that B&B Dental is going to it does in all around the world, or in Italy, where we actually are. So with these final words, I'd like to thank Alan for being with us today, sharing his knowledge about technical things.
And thanks to Angelo to
yeah, thank
explain
you very much.
us the surgical guide
Technique.
and the surgical technique. Yes.
Yeah, and so hope you enjoy this website, and we say hello to everyone, and we hope to meet you in person as soon as possible.
As soon as possible.
Yeah.
Up. Yes.
Bye everyone.
Bye.